We'll move on to our second session. And for the second session, I would like to invite our chairperson, Dr. Swapan Kumar Goswami, Dr. P.S. Chakraborty, and Dr. Joydev Rai. Now, this session is being sponsored by AMRI Dhakuria, and the topic will be on cardiorenal syndrome, will be taken up by one of the eminent nephrologists and transplant specialists of this part of the country, Dr. Arghya Majumdar. He doesn't require any introduction whatsoever. Everybody knows, sir. So, sir, please take up the session. Thank you.
Good morning, Chairperson and friends. I'll be talking today on a very important issue for all practicing physicians, cardiorenal syndrome. This has become very topical of late. Now, first of all, we must realize that all organs talk to each other. And if one organ is diseased or in pain, then the other organ will also be affected. Now, here we are talking about two organs, the heart and the kidneys. And cardiorenal syndrome is a complex pathophysiologic disorder of the heart and the kidneys, whereby acute or chronic disorder of one will affect the other. And we'll see how this goes. Now, this has been classified by Claudio Ronco into 5 types, quite easy to follow. Type 1 is acute cardiac decompensation, which is complicated by acute renal failure or AKI. And this can happen in various conditions like acute myocardial infarction or cardiogenic shock. Then comes chronic cardiac dysfunction, which leads to chronic kidney disease. This can happen in long-standing systolic or diastolic heart failure. The third one is acute kidney injury causing acute cardiac dysfunction. This can happen in, say, acute glomerulonephritis or acute tubular necrosis, acute renal failure of any cause, a snake bite or NSAID-induced toxicity. And then type 4 is chronic kidney disease, causing chronic cardiac disease, say diabetic nephropathy, or polycystic kidney disease, any chronic kidney disease. And type 5 is independent disease like diabetes or multiple myeloma or sarcoidosis, which can affect both the organs. Now, let's look a bit more into this with a case scenario. Now, coming to the first case, this is a 72-year-old diabetic and hypertensive man. He developed sudden crushing retrosternal chest pain while climbing the stairs to his office. He was taken to the ER and TROP-T positive, and as you can see in the ECG, clear evidence of massive anterior MI. Heart rate of 120, BP had dropped to 80/60. He was rushed to the cath lab. Angio revealed triple vessel disease, 98% stenosis in the LAD, and primary PTCA was done. However, he needed intra-aortic balloon support, and no surprise that the urine output started dropping 10 to 20 ml per hour for the next 12 hours. And renal replacement therapy, CRRT, had to be started. So this is a scenario of what I described is acute cardiorenal syndrome or CRS type 1. Here, the mechanisms which come into play are the heart has been acutely compromised and the blood pressure has fallen and there is shock. So, there is decreased cardiac output and there is tissue hypoperfusion. We just heard the tissue hypoperfusion, less oxygen in the tissues, and increased venous pressure. Therefore, no wonder even the tissues in the kidney are affected with loss of oxygen. Then, to treat this condition, we have given contrast. He needed a primary PTCA, and that can affect the kidneys, and also use of other agents in this situation like ACE inhibitors, diuretics, that can be deleterious if not used judiciously. Also, brain natriuretic peptide, these are protective chemicals released by the heart, trying to overcome this situation. There is humoral signaling, monocyte activation, endothelial dysfunction, which causes cytokine secretion, which is damaging to the kidneys. The kidney also, there are simultaneous sympathetic stimuli. You can see the heart rate is fast. The body is trying to auto-regulate, and there is sympathetic activation. And this can be deleterious to both if it overshoots. Now, the important thing to find out in this situation is who is at risk. Say in various situations, I cannot go through all, but say if a patient is going for cardiac surgery. Now, which patient is at risk of developing acute kidney injury? Patient who's been on ACE inhibitor and is continued. Patient with a very low ejection fraction. Patient who's needed intra-aortic balloon pump support before going for cardiac surgery. Emergency surgery, etc. So there are a list of factors which we can identify, because very important to take preventive action, because once it happens, we can't do much. Then let's see another common scenario. Contrast. Now we have to do a CECT, contrast CT. Now which patient will develop contrast-induced kidney injury? You know, patient with very low blood pressure, again, someone who's needing vasopressor support, elderly patient, someone with diabetes, a condition where large amount of contrast has been used, more than 100 ml. Say in these kind of situations, primary PTCA, etc., intra-arterial injection. So it's very important to identify beforehand that which of my patients will develop or has the risk of developing AKI, so that I can take preventive steps. Of course, for the heart, now we have very good biomarkers which tell us within 4 to 6 hours that whether the heart is injured. You know, we have TROP-T and CPKMB, pro-BNP, etc. Now for the kidneys, creatinine is a poor biomarker. You know, that takes almost 24 to 48 hours to rise. So now there is a lot of research into biomarkers like cystatin C, NGAL, etc., which can similarly detect acute kidney injury within 6 to 8 hours. This is still being developed. The other important thing in type 1 HRS is hemodynamic assessment. This easier said than done, very difficult to actually achieve. Initially, we used to use central venous line, Swan-Ganz catheter, and all these. These have gone out of vogue because there are a lot of fallacies in using this. Now we are using more non-invasive techniques, and a very popular technique now is to do ultrasound imaging of the abdomen and look at the IVC and its collapsibility. You know, that tells us about the central volume depletion or hydration. There is a Vigilio catheter, and often in cardiothoracic OT or in critical care units, you can do a transesophageal Doppler monitoring and directly visualize what is the left ventricular end diastolic pressure. And that why how you can say whether the patient is underfilled or overfilled. And passive leg raising is another quick method by which you can determine whether the patient will benefit from fluids. Now, coming to therapy of this condition, well, we treat acute MI as has been stated. We can use diuretics very cautiously. ARNI is started now within first 24 hours, as soon as the patient is slightly stable, and definitely patient should be on a ARB or aldosterone antagonist when the patient is leaving the hospital. In the acute phase, inotropes like dobutamine or milrinone may be used. For renal perfusion, earlier we used to use renal dose dopamine. This has gone out of vogue. Phenoldopam has also been tried. Atrial natriuretic peptide infusions have also been tried. None have been very successful. There is some literature on use of slow continuous ultrafiltration in this acute condition, and the patient is in heart failure, to remove the cardiac load, reduce the preload by scuff, again not been very successful. For prevention of contrast-induced AKI, various methods have been tried, like N-acetylcysteine, but ultimately the most important thing is hydration with normal saline. That has stood the test of time. So, coming to another situation, say a 52-year-old lady with presence with progressive breathlessness and ankle swelling, history of rheumatic fever in childhood, JVP is raised, there is edema, bibasal crepes, ECG shows AF, and there is aortic stenosis, regurgitation, MS and MR with pulmonary hypertension, and this patient subsequently develops oliguria, and urea goes up to 200, creatinine 3.5. This is an example of chronic cardiorenal syndrome, that is CRS type 2. So it's a chronic cardiac condition which will cause chronic renal problems, and the pathophysiology is chronic renal hypoperfusion because the heart is compromised, neurohormonal, like I said, sympathetic stimulation, altered sensitivity of vasodilators. Now, due to genetic or acquired risk factors like rheumatic fever, so there is continuous hypoperfusion of the kidneys, low cardiac output, subclinical inflammation, maybe accelerated atherosclerosis, increased venous pressure, and also due to chronic kidney damage, development of anemia, water retention, etc., that will have a deleterious effect on the heart. So, like I said, organs crosstalk, so this will have an effect on that, and that will have an effect on this. Now, diagnosis, estimation of GFR should be a part of initial evaluation, and we can use various formula, like this is available in apps, the CG formula or MDRD formula, or more popular now is the CKD EPI formula. And as substrate, there are various fallacies of creatinine, because creatinine can be affected by muscle mass, by the food we eat, and various other factors. So cystatin C is a better marker than creatinine, or we can use a combination of these two in the formula. Cardiac output is not a reliable indicator to assess the severity of CRS, and hemodynamic assessment, as I mentioned earlier, is very important. Now, for management of these chronic conditions, again, use of diuretics, low dose dopamine, ionotropes in the acute situation. ARNI is very, very important, ACE inhibitors, tolvaptan, and now, okay. Now we know that dapagliflozin or any of the SGLT2 inhibitors are very important. And in the chronic situation, left ventricular assist devices, cardiac transplant is the definitive treatment. Now, coming to case 3 situation, a 40-year-old man presents with shortness of breath and hemoptysis. You can see the chest X-ray, and there are vasculitic rash, and the urea is shot up from 60 to 130, creatinine from 1.5 to 4.5. There is RBCs in the urine. C-ANCA is positive, anti-PR3. So this patient, the echo shows also generalized hypokinesia, ejection fraction 35%. Renal biopsy shows crescentic GN. So this is definitely a case of GPA or Wegener's granulomatosis, and that has also affected the heart. An example of acute renocardiac syndrome. Now, in acute renocardiac, now, as you know, we have the Rifle criteria or the Akin criteria to diagnose acute kidney injury all over the world, a universal criteria. And how is it affecting the heart? Well, renal shutdown causing fluid overload, pulmonary edema, AKI may cause hyperkalemia, that may cause arrhythmias or cardiac arrest. Untreated uremia may cause decreased uremic cardiomyopathy or decreased myocardial contractility and pericarditis. AKI will cause acidemia, pulmonary vasoconstriction, increased myocardial oxygen demand, reduced myocardial reserve, and myocardial ischemia. And renal ischemia itself may precipitate a surge response. So in CRS type 3, again, acute kidney injury causing hypertension, volume fluid retentions, sodium retention, sympathetic activation, electrolyte acid-base disturbance, these are all affecting the heart. And for management, first we can diagnose the affection of the heart by TROP-I and NT-proBNP to see if there is cardiac failure. Adequate treatment of accelerated hypertension, of medical management of hyperkalemia, of acidosis, and sometimes early use of hemodialysis or CRRT, continuous renal replacement therapy, may be very useful, particularly when the patient is hemodynamically unstable. N-acetylcysteine, like I said, may be used to prevent contrast nephropathy. Coming to the case 4, diabetic hypertensive man, hemoglobin 7, echo generalized hypokinesia. So this is a situation, as you can see in the ultrasound, a chronic kidney disease causing chronic heart. Okay. So this is the type 4, and I'll just touch on type. And just to complete the picture, this is case 5, where secondary, that is independent cause like diabetes or multiple myeloma affecting the heart and kidney simultaneously can cause CRS type 5. I'm sorry I had to rush because it's a very huge topic, but I gave you a gist of the important ways how the heart and kidney can affect each other and how we have to establish a balance so that both can work for the good of the body and keep the body healthy. Thank you.
Thank you very much, sir, for your excellent presentation. It's very difficult to cover the entire subject, but sir has done a wonderful job. We are actually very much tight with our schedule because right from to the evening, lot of good sessions are coming up. We are really fortunate to get sir as our speaker in our conference. And we have launched our YouTube channel. We are not going to disturb any one of our speakers during their delivery. So I would like to request our eminent members and all the guests to go through the YouTube. You will get the entire session. You can see the exact, and whatever you want, you can get it from there. Thank you very much. Now I would like to request our eminent chairpersons to felicitate our eminent speaker, well known. Dr. Majumdar doesn't require any introduction whatsoever. And we are really grateful to MRI Dhakuria to sponsor this brilliant session. Thank you.